Welcome back to the Deep Dive. Today, we're taking a huge stack of clinical guidelines, mostly from the CDC, and we're just cutting straight to the chase. We're focusing on how to manage genital blisters, the ones caused by the herpes simplex virus, or HSV. Our mission is to give you the absolute clearest picture of what works, what doesn't, and most importantly, why the experts are so firm on this.
And that why is really where the big surprise is today. There's this common sense idea that if you have a skin problem, you put a cream on it.
Right. Seems logical.
But the evidence here, it just completely flips that on its head. The sources make it so clear that this intuitive approach is not just a little bit wrong, it's actually counterproductive.
Because we're not just treating skin, we're managing a systemic disease. Okay, let's unpack this. So before we even get to the whole pills versus creams debate, the guidelines say we have to start with the basics. Confirmation.
Exactly.
You present with genital lesions. A clinician probably suspects HSV-1 or HSV-2. But how do we know for sure?
The protocols are very direct on this. Confirmation is absolutely vital, and the gold standard isn't just a visual check anymore.
Not just guessing.
Not at all. The guidelines strongly, and I mean strongly, recommend using LAN-AT or PCR tests,
Which stands for?
nucleic acid amplification test, or polymerase chain reaction. Basically, you swab the lesion, and the test looks for the virus's actual genetic material. It's incredibly sensitive, very accurate.
So you know exactly what you're up against.
Precisely. That's step one before you can build any kind of long-term strategy.
And beyond that lab test, what else does a clinician need to know? Because it's not like it's a one-size-fits-all prescription, right?
Oh, absolutely not.
Yeah.
The initial assessment is really thorough. They're asking, how long have you had this? How bad is the pain? Do you have a fever, body aches?
The systemic stuff.
The systemic stuff. And critically, is this your first time, the initial episode, or has this happened before? Plus, your general health, your immune status, sexual history, all of that feeds into what drug, what dose, and for how long.
Okay, that makes a ton of sense.
Yeah.
You establish the context, you confirm the virus. So now let's get to the heart of this. The thing that trips everyone up. Oral medication versus a topical cream. A pill that works everywhere, or a cream you put right on the spot. And this is where the evidence just isn't even a close call.
Not even close. The sources are completely unanimous. Oral antivirals. So we're talking about things like acyclovir, valacyclovir, famciclovir. They are the definitive first-line treatment, period.
I'm hearing some strong words there. Definitive. But wait, a question I think a lot of people would have is, aren't those oral doses pretty high sometimes?
They can be, especially for a first episode.
Right. So does that mean more side effects? Is that why someone might want to reach for a cream instead, thinking it's, gentler?
That is a fantastic question because that's the exact thought process. And yes, there can be mild side effects, maybe some nausea, a headache. But the guidelines weigh that against the benefit. And the benefit from the oral pill is huge. Well, the benefit from the cream is, it's basically zero.
Zero. Not just a little bit.
For genital herpes, we're talking about a failure versus success situation. It's that stark.
Okay, so we have to dig into that failure. Why doesn't it work? Why can't you just put the drug right on the sore where you can see the problem?
It comes down to where the virus actually is. The blisters you see on the skin, they're like the smoke. But the fire, the actual virus, isn't really there.
Where is it?
After the first infection, it retreats deep into the nerve roots, the ganglia near your spine. It's hiding out in a secure command center, basically. When it reactivates, it travels down those nerves to the skin. An oral pill gets into your bloodstream and it travels everywhere. It can get into those nerve cells and shut down the replication right at the source.
Okay, and the cream is just?
The cream is just sitting on the front porch. The key reason it fails on genital skin is poor penetration. The tissue there is just different from, say, the skin on your lip. The ointment can't get deep enough to reach where the virus is actually replicating.
Wow. So it's a delivery problem. The drug can't get to the factory to stop production.
Exactly. And that has major consequences for the patient, which is why the CDC is so against using it. You get no meaningful reduction in pain. And this is the most critical part. You get no reduction in what we call viral shedding.
Let's pause on that term. Viral shedding. It sounds important. What does that actually mean for the person listening?
Viral shedding is the invisible danger. It's when the virus is active and being released from the skin, even if you can't see a blister yet, or even after a sore seems to be healing.
So you could be contagious without knowing it.
You are absolutely contagious. And reducing that shedding is maybe the #1 goal of treatment. It limits how bad your own outbreak gets. And it dramatically reduces the risk of giving it to a partner.
And the creams don't stop the shedding.
They don't touch it. because they don't stop the replication happening deep down. So you could be rubbing a cream on 4, 5, 6 times a day, which is a pain for almost no benefit. And you're still shutting the virus. You have to shut it down from the inside.
That's a fundamental difference. You're not just treating a spot, you're managing a systemic risk.
That's it, exactly. And that systemic approach gets tailored to a few different scenarios. For a first-time episode, which is usually the worst, you're looking at a longer course, maybe 7 to 10 days of oral antivirals.
Right.
Then you have people with recurrent outbreaks.
Okay.
For them, it's about speed. It's a short burst of therapy, maybe 1 to 5 days, but you have to start it the second you feel that first tingle or burn,
That prodrome.
that prodrome.
Yep.
If you catch it early, you can often stop the outbreak in its tracks or make it much shorter.
And then there's the third option, the long-term one.
Right. For people who get frequent or really severe outbreaks, say 6 or more a year, the evidence is overwhelming for daily suppressive therapy. You take a low dose of the oral antivirals every single day.
And the goal there isn't just treating, it's preventing.
It's all about prevention. It drastically cuts down how often you have outbreaks, and crucially for public health, it slashes that asymptomatic viral shedding, which means a massive reduction in transmission risk to partners.
So no matter how you slice it, systemic oral treatment is the only real path forward.
Okay, let's pivot for a second. We've talked about controlling the virus, but what happens when the sore itself becomes a gateway for something else? I mean, secondary bacterial infections.
A really important clinical scenario.
Okay.
When you have an open sore from HSV, that protective barrier of your skin is broken. And the normal bacteria that live on your skin, like staph or strep,
They see an opportunity.
they see an open door. And they can set up an infection right on top of the viral one. It can turn a simple viral problem into a much bigger mess. And clinicians have to be on the lookout for the signs. They're looking for things that say this isn't just the virus anymore. So increased redness, warmth, swelling that starts to spread. You might even see actual pus.
A purulent discharge.
Exactly. And there's one really memorable sign that screams bacterial infection, something like impetigo. It's the appearance of a honey-colored crusting over the lesions.
Honey-colored crusting. That's a great visual. If you see that, you know something has changed. It's a huge red flag, and this is where the management has to split. Your antiviral pill treats the virus. It does absolutely nothing for the bacteria. You need a different tool.
So what's the plan then, if a clinician sees that?
Well, first, basic care. Keep the area clean and dry. But for the infection itself, you need clinician-prescribed antibiotics. For a really mild local spot, a topical antibiotic cream like mupirocin might work.
But if it's spreading,
If it looks more like cellulitis, a deeper infection, then you need oral antibiotics, and quickly. Sometimes they'll even take a culture to make sure they're using the right antibiotic for that specific bug.
so to recap, blisters and pain, that's the virus, you need oral antivirals. But if you see that honey-colored crust, spreading redness, pus, you need a clinician because you probably need antivirals plus antibiotics. Okay, let's talk about the final piece of this, which is just supportive care and counseling. What simple things can someone do to manage the discomfort while the medicine is working?
Supportive care is so important for just quality of life during an outbreak. Simple things. Gentle cleansing with warm water or saline. Wearing loose cotton clothing to reduce friction.
Common sense stuff.
Totally. And, over-the-counter pain meds like ibuprofen can really help. And of course, and this is non-negotiable, avoiding all sexual contact until everything is completely healed.
Right, to prevent irritation and transmission. Now, there's one more big public health point in the guidelines that we really need to highlight.
Yes. This is standard procedure. The presence of genital herpes lesions is a sign of potential sexual health risk. So the CDC guidelines recommend that all patients who present with genital herpes should also be tested for HIV.
And it's important to say this isn't to cause alarm.
Not at all. It's because HSV lesions can make a person more vulnerable to getting HIV, and having both infections can change the treatment plan. It's just part of providing complete responsible care.
So let's boil this whole deep dive down. What are the absolute must-know takeaways for the listener?
I'd say 3 things. 1, this is a chronic condition, but it is 100% manageable. 2, oral medicine is the only proven effective treatment for genital HSV.
And 3,
That topical cream, the one that feels so intuitive, it's just not going to help you with genital herpes. It can't stop the viral shedding, and that's the whole ballgame.
that really is the core nugget. Oral therapy is mandated because it's the only way to get the drug deep into the nerve ganglia and stop that viral shedding.
Mm.
So what does this all mean? It means the choice isn't just about the right drug, it's about choosing the right delivery system to fight an infection that's hiding deep inside your body.
And that actually leads to a final thought for you to consider. We talked about how daily suppressive therapy is great at reducing shedding. So think about the bigger picture. When you factor in the constant need for counseling, managing relationships, and preventing transmission, what role could widespread, long term suppressive therapy play? Is it just for controlling one person's symptoms, or is it maybe a powerful, underutilized tool to dramatically lower transmission rates across the whole population?
A fascinating look at how individual treatment choices can scale up to become public health strategy. Thank you for joining us for this deep dive. We hope this gives you the clarity to tell the difference between what works and what's just a common myth.